Okay. Hi and welcome everyone. My name is Cassandra Ferrugia. I am NAMI New York State's Communication and Engagement Specialist. And today we will be concluding our Wellness Wednesdays discussion series with a part 4 multicultural.
Unmute.
Recording in progress.
Hello, everyone. Good afternoon. My name is Cecile McIntosh Green. I am the current secretary for the NAMI New York State Board of Directors. I'm also chair of the NAMI New York State Multicultural Committee and the co-chair of the Educational Conference Committee. Welcome to our event. I trust that you will enjoy it. I trust that you will walk away from this with some insights. I trust that you will be enlightened by what is shared. And thank you so much for joining us in this special event. Next on our list, or the first speaker.
Sorry, Cecile. Before we introduce anyone, I just wanted to mention Angela, if Angela wants to come off mute. Sorry.
Yeah, sure. Hi, everyone. I'm Angela, and I'm going to be graphic recording today's session. As everybody is talking with our great speakers, I'm just going to be here doing the visuals of the notes. If you want to pin my screen to see me draw, you can. But you'll get the result at the end of the meeting. Thank you.
Okay, thank you. Cassandra, thank you. So as I was saying previously, our first speaker will be Tina Lee. Tina Lee is the Executive Director at Twin County Recovery Services, former Community Education and Outreach Manager at NAMI New York State, and former Executive Director at NAMI Mid-Hudson. Let's welcome Tina. Thank you.
Hi, Cecile. Thank you so much. Everybody can hear me, correct? I think I keep on forgetting to unmute myself in all these Zoom meetings, but thank you so much for inviting me today. I just wanted to give a quick overview of Twin Counties. We are an OASAS licensed agency that provides treatments for individuals impacted by substance use disorder in Columbia and Greene counties. And as Cecile mentioned, I've had the privilege to work at NAMI. As many of you who know my story, NAMI really saved my daughter's life. And I am forever grateful for the skills that I acquired through NAMI's education to support my daughter's recovery, as well as learning very effective advocacy skills, which are so important, I think, especially for this topic today, to learn how to navigate the mental health care and substance use disorder system, especially as a person of color and as a family member. And, I work with all the communications skills that I learned in the work that I do today. I also sit on the statewide Multicultural Advisory Committee, otherwise known as SMAC, at the Office of Mental Health. And the SMAC has been charged with creating a strategic plan and overseeing what we hope is really transformative change, to the mental health care system to address the disparities among marginalized communities, such as BIPOC, LGBTQ+, and the Latinx community. So I think all of you can agree that your zip code really determines your health outcomes. And during COVID, I think we all could see that it really did not help. In fact, I think it acted like salt to a wound. It made it even more apparent that the health disparities and inequities exist, and it's not an aberration for our marginalized communities. I'm sure many of you have seen the studies that have shown that whether infected or not, minorities and those underserved communities and others experiencing health disparities are at double the risk of long-term mental health impacts from COVID-19. In my line of work, we've seen that COVID-19 has severely exacerbated inequities, particularly in substance use. There was a 20% surge during COVID. Over 83,000 drug overdose deaths occurred in the United States in the 12 months ending in May 2020. And this has been the highest number of overdose we've ever seen recorded in a 12-month period, according to CDC. And, it's unfortunate, but the CDC doesn't track overdose deaths by race. But we have seen a growing body of research that has suggested that Black Americans have suffered the heaviest toll in the substance use community. And what's interesting is too that for whites and who are financially well off, substance use disorder is often treated as a chronic and survivable illness, and that means long-term health care and these life-saving medications such as buprenorphine. But in contrast, many of the people of color and poor Americans experience addiction at a very different perspective. They face arrest, incarceration. They rarely gain access to high quality care. We actually see many treatment deserts in many Black and brown communities. We see that Black and brown folks are 35 times more likely than whites to be denied prescriptions of buprenorphine or any other medication assisted treatment plans, which is absolutely egregious. There should not be a color definition of who is getting treatment or not. So, at my agency, we work with a lot of folks that are dual diagnosed, which means that they have mental health conditions as well as substance use disorders. And so we're facing double the challenge. And, if you are a person of color living in a rural community where access to care is even more difficult, even without a pandemic, we are dealing with a huge hurdle in receiving treatment that we all deserve. So I wanted to go back a little bit talking about what SMAC is doing. We are reviewing internally and externally the way agencies do businesses. And what that means is that we're looking for agencies that are adhering to what we call the 15 class standards. And these are a set of 15 action steps intended to advance health equity, to improve the quality and help eliminate those healthcare disparities. And it's providing a blueprint for individuals and healthcare organizations to really implement culturally and linguistically appropriate services. There's also a focus on increasing workforce diversity, and we are asking agencies, are you a JEDI agency? Are you supporting justice, equity, diversity, inclusion? And we're looking at the recruiting process, at your website, your employee handbook. Are you using JEDI language, neutral pronouns, diversifying your workforce? I also wanted to talk about some advocacy work that Congressman Paul Tonko is implementing. He's joined a bipartisan coalition to introduce House Resolution 364 to support the substance use disorder workforce, to make sure that we deliver evidence-based programs to address SUD populations. And this means that we're going to open up the talent pool and to support that workforce diversity. So I really want to ask all of you, what you can do. And I think the answer is that we need to continue to chase public policy. We need to decriminalize acute mental health and substance use disorder crisis in our communities. So, I know NAMI is big on education. So I think we all need to become mental health and substance use literate. I like to give the example that for most people, if you see somebody choking, we all know the Heimlich maneuver works, right? If somebody needs CPR, we know either to deliver it or we know where to go or ask for help. But it's unfortunate that we still see that people with mental health issues or in crisis, that we don't know the signs and symptoms. We don't know where to go if somebody is overdosing, or even to ask the question if somebody is experiencing suicidal ideations. So that's where, I am a big proponent of education, because it empowers and it is also powerful. Take that NAMI class, take a mental health first aid class, post a Narcan training, get a Narcan kit. It's free, right? Learn how to administer Narcan, because you never know who may need that. It's people are always saying, is it in my backyard? It is. It's in our communities. And, again, advocating and scheduling a crisis intervention training as well in your community. So keep the voice up, right? And, the last thing I just wanted to mention is talking about cultural humility. I think everyone has been very familiar with the word cultural competency, and it's been, ubiquitously used as a cornerstone in our mental health care system for over 30 years, right? It's the ability to engage and be knowledgeable with people across cultures, And it gives that assumption that the more knowledge we have about that culture, the greater competency we have in that practice. However, we know that cultural competency really hasn't fostered that cross-cultural communication or reduced health disparities or even improved access to care or increased health literacy or promoted health equity. In fact, it's the opposite. We see that there are problems, with that if an individual, say a clinician, attains that knowledge that, they know that group of person, it really could lead to stereotyping and bias. And it really implies that, once you're competent, you're done. But we know that it's a lifelong process to understand a culture, right? There's many, I'm Chinese, but it doesn't mean that, once you know me, that you know everything about the Asian culture, right? So this is really a process that I think is about self-reflection. It's about personal critique, to be open and honest. And it's that cultural humility to be able to come into a situation as a clinician, as a community member, as a family member, as an individual that's struggling, to be open and unbiased. So, I think it's important that we also discuss, that intersectionality is not focused upon as well. We know that, again, one size does not fit all, and to understand one culture doesn't mean that you understand everyone. So I am really hoping today's discussion that we need to study these disparities in a different way. What a lot of people do in research is to control these variables. We only look at sex, race, ethnicity. But instead, we really need to look at these different identities. We have to show that we all face unique barriers to health, and to truly determine what causes these disparities, we have to be careful about how we study these disparities, because our conclusions really matter, because we know that everybody has a different experience. So I'm just going to close and say that, I encourage all of you, whether you're a professional in the field or a community member, please stay curious, become mental health and substance use literate, practice that humility each and every day, because this is how we are going to truly address these health disparities and to promote health equities, to change attitudes and save lives. So thank you very much for the time.
Okay, thank you, Tina.
Yeah, so now we'll open the floor for questions. If anyone has any questions for Tina about the work she's doing, please put them in the chat. And just as we wait to get a few questions, Tina, can you share a little bit more about the work you're doing now at Twins Recovery?
Sure. Well, as we were talking before we went live, we are seeing an enormous influctuation of the use of fentanyl in the drugs that are out there. As I always like to say, it's not grandpa's pot anymore. It's extremely addictive. It's extremely deadly. So Schenectady last Thursday had 17 overdose. I think one was fatal. We are seeing such an increase in overdose that it's frankly scary. There's a new synthetic opioid out there that is not detectable in most of our testing. So, what's unfortunate, many of the overdoses we're seeing are people that have been in recovery and they've used and they've lost their lives. So, I think one of the things that we need to focus, at Twin Counties, we are really increasing that education. We have a program called Greener Pathways, where they go into the community to educate the community in giving out free Narcan kits. Also hosting that Narcan training is very important, but it's manned by people that are equivalent to peer specialists. They're called SERPAs. They're certified recovery peer advocates, and they have the skill to really talk to that person if they need the help. Another focus at Twin Counties is bringing on harm reduction. And I think that's a very controversial, which it shouldn't be. It's really about reducing risk and meeting the client where they are. And, I think a lot of people are nervous thinking that it's about encouraging drug use. It really is not. It's encouraging folks to get the help when they need it. Again, giving a good example is that if somebody is using heroin, but if we can encourage them to use safely, we decrease their chance of overdosing. using safe needles, right? Or if, they need to, if they're going to use marijuana instead of heroin, we're moving toward recovery, and it's different for everyone. So again, I think it's really important that, we keep an open mind to things like harm reduction and meeting that client where they are. I think, Phil, you've asked a question, right? So the strategic plan, we submitted our plan recently, so we're waiting to hear back from the higher ups, but we've already started a lot of implicit, explicit training for people from the top down, bottom up. So I think that is a really important place to start, is to really look at your institutional biases, right? So we're working at that, working at all the OMH agencies to also review, like I said, the way they do business. I know that we've had discussions too about grant funding to make sure that if your agency is not JEDI, it could really impact the funding stream. So we're hitting people where it counts, is where the money is. So, we're hoping that agencies will start addressing, honestly, are they doing the right thing when they are hiring somebody, and they're not hiring a diversified workforce? Is their strategic plan include people of color? Even, we've worked with some agencies where their services are not language accessible. So just basic things I think are really important. Again, that keep these conversations open. But the work is going to be tough. We all know that there's been discussion about merging the two O's. That's going to be interesting too, to see what that structure looks like. But a lot of work ahead. But it starts, I think, with us, within ourselves too.
Right. Thank you so much, Tina. Thank you for all the work you're doing in that. As you mentioned, harm reduction is so important. Just it's life-saving when we can end overdose. We're saving lives, and that's so important for all of us and all our communities, right? It touches everyone here. So now, Cecile.
Yes, ma'am. Hello. Our next speaker is LaShawn M. Paul, DSW, LCSWR. She's the owner and lead clinician at Social Work Diva, a telehealth provider of mental health therapy for women. Welcome, LaShawn.
To speak and forgot to mute myself. Hi, my name is Dr. LaShawn Paul. As Cecile mentioned, I am the proud owner of Social Work Diva, an online provider of therapy for women in New York State, centering Black women. In addition, clinical supervision. And then the third arm is private practice consulting and consulting for local politicians to shape and shift mental health agenda. One other thing that I'm heavily involved in is I am a New York State, well, let's start with the city first, New York City ambassador, a NAMI ambassador. And then I recently became a NAMI New York State Multicultural Committee member. A lot of my life work centers around Black women, as I've mentioned. And to start you off a little bit in understanding how I've came to this work was at the age of 17, I lost a friend to suicide. One of the things that I easily picked up and recognized, and what led me to social work, was that I recognized that I didn't want women and teens to feel isolated and alone as she did, as she internalized some of the messages and the stigma that was ultimately fed to her by her mother, who told her not to share with her friends that she was depressed, that people thought she was crazy, and that ultimately she should pray it away. These are some of the same messages and attitudes that a lot of Black women culturally have towards mental health. And we see with them that there is a significant increase, right, in regards to disparities of what it is to be both Black and a woman, as Tina mentioned, in regards to intersectionality. One quote that I actually really want to read with you to better understand intersectionality, particularly with Black women, is a quote by Bell Hooks. And she states, no other group in America has so had their identity socialized out of their existence as Black women. When Black people are talked about, the focus tends to be on Black men. And when women are talked about, the focus tends to be on white women. What does this mean for our mental health? Black women typically have different experiences than Black men and white women. So this erasure has significant implications. It's an issue in regards to sexism, but also racism that ultimately affects Black women's mental health, with origins that originate from slavery and have been passed on, as everyone can probably speak about in this room. The two A's have always been denied, historically and contemporary. And those two A's are in regards to access and awareness. Women are 70% more likely to experience depression and 60% more likely to experience anxiety disorder in their lifetime. And African American adults are 20% more likely to experience a serious mental health problem than a general population. When you couple these two data together, because there's very limited data in regards to Black women's research, one, for us not participating in it, also us not leading those researches, or even making it an issue to really center around Black women researchers, I myself find it I was underwhelming the amount of research that I was able to even pull together for my doctorate capstone that was focused on closing the gap in Black women's mental health. Not only are these factors, Black women are just at minimum too dually marginalized, right? We're not even considering some other social determinants of health, such as sexuality and social economic status, that also creates a prevalence in mental illness and adds to increase. Some other barriers to treatment in our community, as I mentioned, along with just my friend that was a teenager, but what we're still experiencing is significantly the strong Black woman schema, the Black church stigma, lack of mental health literacy that was mentioned, which is just the knowledge and skills in order to recognize what mental health issues or illness is and receive treatment ultimately before it actually becomes a mental illness. The lack of culturally competent treatment is another big thing. So it's because, especially within our field, as in social work particularly, 73% of our field is white. So that means that there are very few Black providers able to meet the needs of this community that has ultimately seen increased levels of mental health issues. This in itself, in addition to countless other things, have created a distrust in the healthcare system, and individuals just necessarily feeling that they don't know how to ultimately access this information. So a lot of what I do is working to change attitudes towards mental health treatment. And within Social Work Diva, but also through NAMI, my goal is to ultimately use that. My doctorate from USC is in social innovation. So it's sitting there and trying to identify really and truly what are the problems, how can we provide innovative solutions. One of them is to ultimately, like as a social worker, I don't know how many of you are in the audience social workers or familiar with them, you'll hear about meeting people where they are. And oftentimes people are on streaming sites, people are watching documentaries. And so one of the things that I came up with was for ultimately to work as a documentary producer with the director, Lisa Durden, to create now what has turned into a docuseries about mental health in the Black community in 3 parts. So one part focuses on Black men, another part on Black women, and another part on Black children. Originally, because my work was solely in Black women's mental health, I decided to focus there and then recognize that as pillars in the community, how could we not help alleviate some of the mental health issues and disparities by providing knowledge to other members of the community so that they could be empowered also to do their work. Changing help-seeking behaviors requires ultimately replacing these negative attitudes, as I mentioned. So one of the things that we've done is create more information. And I really feel like my organization, while it used to be a one-person show, has become this mighty thing where I've ultimately been able to collect and connect with various different organizations within the mental health space so that we're not operating in maluse, right? Oftentimes people would say they go here for this and here for that, and ultimately aren't really sure how to ultimately navigate the system. So my goal is really and truly to be a connector to those things. I have other different things in the works that I can't really talk about right now, in order to link people to, and even for them to even know what's going on in the community and other spaces, but also recognizing that as much as I do telehealth and a lot of people, and even right now we're virtual, that there is a digital divide in this community. So a lot of it is to connect with various different organizations throughout the city, but have been even expanding nationally to ensure that individuals and even politicians mainly, we're in the process of working with the Congressional Caucus for Black Women and Girls, in addition to other politicians who have all either already sat down for the documentary when they worked on the Emergency Task Force for Black Youth Suicide and Mental Health, to describe it, but also recognize and even be educated by experts on really what's going on so that they can help close gaps on literally the policy side. I always say policy is my love language. So as much as I consider myself a clinical social worker and do micro work, I understand the importance and the ramifications that including that macro policy work has on actually eliminating barriers to access. My goal, as just in general, as I said, is to empower individuals and bring people together. And even within that, we have like a rebranding actually happening soon where Facebook is sending us for the summer a paid intern in order to create mental health literacy for Black women, but just even in regards to the community. And we build brand partnerships with other brands that aren't stereotypically a part of the mental health space in order to begin to do events and other different spaces where people who, especially because of the exacerbation of COVID, have been significantly impacted by mental health issues, in addition to the racial climate that we're experiencing right here in America right now. I actually don't have much else to add, so I can open it up for questions if anyone has any questions for me in regards to Black women's mental health. I definitely will leave my email address because in July, we will actually be pushing forward a mental health campaign called Redefine Strong to help women in general, but centering Black women for Mental Health Minority Month, so that we can get them to recognize that strength isn't necessarily a bad thing, right? So using that strength to their advantage and helping them redefine strong as help seeking. So if anyone wants to participate, share resources in that, please do connect with me. Thank you.
Great, thank you so much, LaShawn. And then I'll also just mention that LaShawn is also a member of our multicultural committee, and we are also partnering together to work on a few different events for multicultural mental health awareness. Sorry, let me go back. Minority mental health awareness, or as we call it, Black, Indigenous, People of Color Mental Health Awareness Month as well. So we are planning 2 different educational events. So keep looking for more information about what we'll be doing in July, and we'll be holding another NAMI Cafe, and we'll talk about that later as well. So if anyone has questions for LaShawn, please put them in the chat. And just for now, I have some questions too. So, you mentioned the Black Youth Suicide Prevention Team. Was that what it was?
The Emergency Task Force that was created, I want to say in 2019, that kind of finalized right on the cusp as COVID happened, that ultimately said that pretty much Congress needs to, then it was recommendations for Congress, and then COVID happened, right? That ultimately said that they pretty much need to create an infrastructure to ensure that Black youth are provided mental health treatment in somewhat in the schools was the recommendation. So Michael Lindsay out of NYU, along with, I believe, Taraji P. Henson, that's the day that we were there recording in DC. So Taraji P. Henson was there providing what she's experienced as a teacher, and as a mental health advocate in that space. I know David Johns out of the National Coalition for, I'm gonna mess it up, but they're actually the national provider for LGBTQ. I don't want to mess it up. David Johns, I'm gonna actually tell you what it is. National Black Justice Coalition. So I always mess it up because I always say the acronym and I always get it wrong. So they're the premier organization, and they handle a lot of like Black mental health, but Black civil rights issues for LGBTQ community. And I think that they ultimately have lots of discussions on how mental health providers can also operate within the correct lens and meet their needs. Without judgment, but also maintaining cultural competence within that population. So I think that they brought on a great amount of experts, but also advocates to lead discussions, but also get people in the community involved on starting to do things, right, that are mental health related, and even educating parents on some of the signs and symptoms of mental health, right? As someone from New York City, which unfortunately we lost during COVID, right, was that Thrive NYC had free mental health with a mental health first aid trainings, right? And that was eliminated immediately as of COVID. And I'm like, just go digital for us, please. Because now I felt that it was more needed more than ever. And individuals weren't able to access it, right? They either have to pay for it and either pay for the trainings. So a lot of us were either who didn't get on before were not eligible for the trainings or weren't able to get this mental health literacy in order to help individuals, right? So not only help individuals one-on-one, but also empower communities ultimately with education. So that was unfortunate loss also.
Right, thank you, yeah. And I know I still have some more questions for you, but we'll save it for the end. And now, Cecile, you want to introduce our next speaker?
Mute. Cecile, you're on mute.
Okay, so Cecile, I'm not sure if you can hear me.
Oh, yes, I can hear you. I had muted myself. I'm sorry.
Okay. No, it's okay.
Hello, everyone. Let's introduce Mr. John Johnson. Mr. John Johnson is the Queensbridge Project Director at NAMI Queens Nassau, and he's a well-rounded individual. Is able to share his insights about the subject matter. Thank you, John, for joining us.
Thank you. That was a really scary picture that was up there. But anyway, I am John Johnson, and I am, that is really my name. I'm a junior as well. I'm very proud of my name as being a junior. But let me just really talk briefly about why I am a part of NAMI and their programs. I was diagnosed when I was 17 years old as someone who was diagnosed with bipolar disorder. And living with bipolar for all this time, I was able to navigate, manage, and do pretty well throughout my life. I was my last job before I started working with NAMI was I was the director of one of the directors of a Boys and Girls Club. And I was sitting in my office one day and I said, you know what? I want to do more to kill the stigma, especially for Black and brown folks and Black men in particular. And I said, you know what? I wonder what organization I could hook up with or to align myself with that could kind of help me share that message of killing the stigma. And I had a chance to see a brother speak from Queens Nassau, and he's a national figure. Come to find out, he lived about 5 minutes away from me. I had a chance to speak with him, and thus I got the ball rolling, working with NAMI Queens Nassau. When I first got to NAMI Queens Nassau, I was doing a lot of ending the silence, going to schools and talking to students and doing peer-to-peer. But they had me going to a lot of schools and communities on the Gold Coast of Long Island, which is one of the richest areas in the United States. And it was fine, but I was speaking to people who did not look like me. I wanted to really to get into talking to Black and Brown folks. I know LaShawn was talking about access and awareness. I want to bring that access and that awareness into the Black community. So I started doing things in Queens at churches and stuff like that. Well, fast forward to 2019, NAMI National and NAMI New York State got involved with a project with a brother by the name of Meta World Peace. I don't know if you guys are familiar with him. His name was Ron Artest. He's one of the greatest basketball players out. He played for the Los Angeles Lakers, and he also lived with mental health challenges. Well, he wrote a book, as well as they did a documentary on Showtime about his life. And he's from the Queensbridge community, which is the largest housing development in the United States, with about 7,000 residents. Well, he came, NAMI hooked up with him and Showtime, and we put on an event in the community where he presented his book. We did a clinic, we had food, music, Tina was there, Matt was there, we had a great time. Well, it was such an overwhelming, great experience for not only us, but the people in the community as they were sharing their stories with us, coming up to us saying, you know what, my son, my daughter, my uncle. And so that gave us the impetus to say, you know what, we should do something right here in Queensbridge. We should come right here to do something in the community and not have them go too far and look places and have that access and have that awareness. After the event, NAMI decided that we were going to do this program. That was 2019, October of 2019. So we were going to get things kicked off, of course, in 2020. But of course, the dreaded COVID hit us. And so, of course, we could not proceed like we wanted to. We did some virtual things, but we really needed to be in the community, we felt. So fast forward to now, 2021, we decided to now go into the community. And as of June 16th, we're going to have a big Queensbridge town hall meeting where the residents are going to be participate in just kind of like a discussion about mental health, mental wellness in the community. We have a couple of people, as some of you might know, Queensbridge is really famous for some pioneers of rap like Nas and Roxanne Shante, really popular rap figures. And they're all on board to speak about their community and also speak about the importance of mental health. So we're going to be doing that. We're also going to be doing an event with Meta World Peace, again, coming back to the community. And then we're going to start programs. We're going to have a couple of programs where a family-to-family program where we're going to be talking to caretakers and trying to have like a course where we could discuss what they could be doing to help their loved ones. We're going to have a peer-to-peer program. We're going to have definitely some youth events so we could get the awareness out, but also to really specifically deal with those that are living with and those that are caring for people with mental health challenges. So we're really excited about it. It's really getting a big buzz in terms of us coming into the community, as well as people just really wanting to share. So we're looking forward to it. That's really kind of all I want to say about that. We know the importance. You hear the statistics about mental health in the Black community. In fact, we did a seminar on mental health in the Black community about 2 weeks ago that was really well attended, and we had a clinical social worker. I wish we had LaShawn, but she was really good also. And we just talked about from slavery and the vestiges from slavery all the way to today. and all the things that are being dealt with in the Black community. So we are very excited about it. We are looking forward to, just helping as much as we can. So that's basically all I want to say.
Okay, great. Thank you so much, John. So if anyone has any questions for John, please put them in the chat. And again, we'll wait till the end and we'll also answer a few other questions for all of our panelists. And just to mention, the Queensbridge project is something that we're hoping, we can bring throughout the state into different communities, and kind of just going off what LaShawn said, meeting people where they are and kind of using that framework to really work in the communities, ask community members, what do they need? But instead of just saying, hey, this is what we think you need, right? Getting in there, learning from peers, from people with this lived experience, so we can really make sure that we're creating programs and that are accessible and actually needed for everyone. Okay, so it doesn't seem like we have any questions right now, so we will keep moving. Oh, when will these events take place, John?
As I said, June 16th, we're going to have a kind of a town hall meeting, and then starting in July, when we have a big kickoff in the community. We didn't set the date yet, and then the programs will start probably towards the end of July, beginning of August.
Awesome, great. And also, I'll just mention that John is also part of our multicultural committee. So, as a team, and I'm sure we'll be looking for others. I know someone else asked how to get involved, so we can talk about that at the end as well, for expanding and figuring out how as a state we can all, provide support for each other and create more programs. And now, Cecile, if you want to introduce Philip.
Yes, I will. And I got caught again. I muted myself. Anyway, folks, this is the nature of life in the remote world. Anyway, Mr. Philip Williams Cook is a peer specialist at Fountain House, and I'll leave it to him to explain all his added accomplishments. Go ahead, Mr. Philip.
Thank you, and thank you to NAMI-NYS State for extending me this invitation. My name is Philip Williams Cook. I am a peer specialist at Fountain House. I participate in the social enterprise program, which gives our Fountain House members the opportunity to work. And for those of you who don't know what Fountain House is, it is a psychosocial clubhouse. Its main headquarters in Manhattan. They also have an extension in the Bronx. And there's a lot of different programming that is offered at Fountain House. There's the work order day, then there's evening and weekend programming, which is what I'm a part of. I facilitate several groups a week through Fountain House's Peer One line, and it's called the Open Zoom Room. And then on Saturdays, I put my DJ hat on and spin some tunes for fellow Fountain House members and take requests. But most of my work, though, is sort of outside Fountain House. First of all, I identify as a person of color, African-American, Irish, English, as well as LGBTQ male. And I think one of the panelists mentioned earlier about the rise in, substance use challenges as a result of, the pandemic. How some people cope with the added stresses of life, the changes in scheduling, their daily routines. And so I just want to say I am very proud of all of my identities. I embrace every single identity that I share with you because we as individuals are we're multifaceted. There's many different parts of us, and no one identity, defines us. Especially, our mental health challenges, our substance use challenges. Those things I believe do not define us. We're more than a label, than a diagnosis. So many of you here, I'm very, very sure, have accomplished great things in your lives and will continue to do so. No matter, what your race is, ethnicity, culture, sexual orientation, socioeconomic background, gender identity, gender expression. We all have something that we're proud of. And then there's work to be done still. So much work to be done. And I've been doing that work in many, many different ways, through letter writing campaigns to, my local, regional, state, and national officials, raising awareness about mental illness, the mental health challenges, substance use recovery, that we exist, we're out there, and we're making a difference, and we want to be heard, and not just, have lip service, but we have ideas, we just want a seat at the table. And I'm a big quote person, so I just like to have two quotes from, the late Shirley Chisholm. She was the first woman and the first woman of color as a presidential candidate, 1972. She also served in Congress at that time. And so I love these two quotes. The first one is, "You don't make progress by standing on the sidelines, whimpering and complaining. You make progress by implementing ideas." And this is my absolute favorite quote: "If they don't give you a seat at the table, bring the folding chair," unquote. Oh, I love that one. That's been my motto for the past 12 plus years that I've been doing peer support work. Sometimes you just got to do that. It's, yeah, I mean, I don't know what else to say about that, except that, that's been my motto, because I have a voice, I have a pen, I have ideas, and, I deserve to be heard. We all deserve to be heard. And we all deserve to have a stake, a place at the table. Even if you have to bring a folding chair right in, do that. So I'd like to end by saying, so most of the work I do now is regarding a coalition called Access to Recovery. The main organizer is Frankie Herman. That's FRANKIE HERRMANN. I will put that in the chat, and pronouns they, them. And so the coalition, the Access Recovery Coalition, has meetings the first Thursday every month from 3:30 to 5. And so we have become a voice for to help implement changes to the health and recovery plans. It's ongoing changes. It's changing the core. And so we've been working very closely with OMH to implement town hall meetings. So if you want more information, or if you want to join Access Recovery, I will put all that in the chat. But I want to leave you all with this. Just like the Black Lives Matter movement that started, well, I mean, I want to say it started, but it increased dramatically last year. You have a voice. You have a voice. You have a pen. You have ideas. Don't be afraid to bring those ideas to the table. Don't be afraid to speak up. People will listen. Thank you.
Thank you so much, Philip. And, just going off of what you said, sorry, just thinking about the great quote you mentioned about bringing a folding chair if there's not room for you there, right? Or using your voice, really, making sure that we all continue doing that work. And right, these times right now have really showed us what activism and advocacy and self-advocacy can really accomplish. And we have to just keep fighting for our communities in all these different ways. So important. So we will introduce our next speaker.
Yes, our next speaker is Mr. Frank Sherney. I hope I'm pronouncing that right, PhD, Dr. Frank. He's the current Executive Director of the Rural Outreach Center. Thank you for joining us.
Thank you for the invitation. I'm going to try to share my screen. You need to turn it over to me, Cass.
Yeah, yes.
Yes.
So a little background. My PhD is in physiology, and I had a 45-year career in academics. Currently a professor emeritus of pediatrics at the University at Buffalo. Went to seminary and got turned in a different direction. Currently the executive director of the Rural Outreach Center, focusing on rural issues. So I'm going to try to give a perspective on ruralness as it relates to mental health. So our mission is to break the cycle of rural poverty. On the right, you see two maps of our service areas. So we're located someplace right in here. The area that we serve is a broad southern part of Western New York. It's about a 50 by 50 mile area that we serve. And this purple map shows the number of residents in the different zip codes that we serve. And you can see that some of them are pretty empty. So that's one of the issues that we deal with in terms of our approach to mental health illness and health disparities. The other thing is we deal with a pretty poor population. You can see income, median household income. There are some areas here with quite low household incomes. So we deal with a population that has these kinds of issues that they're trying to deal with on top of everything else. In Rock County, which is what we call these zip codes that we serve, there are over 46,000 people in poverty spread over this 50 by 50 mile area. They are therefore invisible. Making them even more invisible is the fact that over 8,500 of them are without a car, without any transportation. There's no public transportation, there's no Uber, there's no nothing to help these people get to wherever they might be. So as a result, they have no access to services. Kids have no access to extracurricular activities and normal childhood experiences that most of us would take for granted. There are over 2,800 in Rock County without a phone, so they have no way to communicate with anybody. In some of our kids, the phone would be ahead, if they had them, would be the only access they would have to internet. So many of our kids have no access to internet for schooling. 1,100 are without with limited cooking facilities, 800 without fully functioning bathroom facilities. And as a result of all of these disadvantages in our rural areas, there's a very high incidence. In fact, as a percent, the incidence of mental health disorders, suicide, domestic violence, drug abuse, and so on and so on and so on, is higher in rural areas than in metropolitan areas. Now, that's not to say that the numbers are greater, but that the incidence is greater. Because the population is dispersed over such a broad area, it's difficult to provide services. So there's been a complete lack of public and private investment in our rural communities to try to address these issues that our folks are dealing with. One of our issues is trying to deal with generational poverty. In our families, the primary issues are housing and the availability of services, and including healthcare. I'll show you a map in a moment on the availability of mental health services in our rural areas. So availability is a huge issue. Some of our participants are being asked to drive 50 to 60 miles to get any kind of service whatsoever. Of course, that means that they don't access these services. But even if the services were more available, because of the lack of transportation options, they simply do not access them. The big issues in our adults are training and employment opportunities. The big issues in our children are to provide a sense of hope and a vision, a different vision for their futures than what they can see in front of them right now. We have a program that's a wraparound program recognizing, as was mentioned earlier, it's ridiculous to provide mental health services to someone and then send them back into a toxic environment. So our approach is to provide whatever services they might need using over 90 different partners in collaboration. So for our children, this is particularly important because they have no access to extracurricular activities and other sorts of opportunities that might allow them to envision a brighter future for themselves. So here's a map of mental health service providers. So the black line outlines Rock County, our service area. And you can see wherever there's a village or a town, that there's a fairly high concentration of mental health providers. Beyond that, though, it's a virtual desert of mental health providers. So again, availability is an issue and access is an even greater issue. So we've developed what we call an empowerment model. We listen to our participants. They come to us and of course everybody is trained in and uses motivational interviewing to help these individuals identify their problems and possible solutions. And then they sign an agreement saying, I am willing to do this work to put myself into a better life situation. We sign an agreement saying, good, we will provide these resources. We minimize barriers, we provide gas cards and so on, transportation should that be needed, childcare and so on. And as I said, we consolidate wraparound services so that they aren't forced to go from one place to another to receive the services that they need. They can get virtually everything they need, including mental health counseling. As an academic, as a scientist, it's important for me to measure what we're doing. So we measure progress in these social determinants of health on a 0 to 5 scale. So when we say we're making a difference in people's lives or they're changing their lives, we know it because we measure it. In any given year, we see over 50% of those participating in our programs improve on their mental health status, their employment status, their health and housing status. So we're making a significant dent in the issue of poverty in general and mental health illness in particular. Our focus to break the cycle of poverty is on kids. So we try to develop character in our programming. They earn what we call rock bucks by doing certain things on their own, taking the initiative. And they can use those rock bucks, for instance, to treat their family to movie tickets, or they can use them to buy Christmas presents for their family, which is a really wonderful thing to see. We offer an intensive therapeutics program with a focus on theraplay and play therapy in addition to other modalities, but play is our primary therapeutic modality. So if we look at our population, these are the 6 primary disorders that we tend to deal with. Every one of our children have been traumatized. Let me say that again. Every one of our children have been traumatized in one form or another. So you know, they're in a deep hole that we're trying to help them get out of. And here again, we measure change and as with the adults, over 50% of our kids move from you know, on a scale from a 1 or a 2 to toward a 5, the highest they can achieve. So that's it. My point is that culturally the rural population is different. They have problems that are different from metropolitan areas, but in some ways similar, and they require different solutions. Thank you.
Great, thank you. And now we'll open up for questions, or you can ask, you know, throw some questions in the chat for all of our different panelists. And if there was anything any of our panelists did not get to mention before that they saw in the chat that they'd like to address before we close today.
So I put the information in the chat about the Access Recovery Coalition. Sorry to put the word coalition, but Access Recovery Coalition. That's the main contact, and I hope folks in here and your network will consider being part of this important work through Access Recovery Coalition. So I have one question. I guess for those who are in the Multicultural Advisory, the Multicultural Committee, NAMI, how do I become a part of that?
Okay, I can give you a call later.
Okay, not a problem.
All right, I am the chair of that committee. I'll give you a call later.
Okay.
Thank you very much for your interest.
No problem.
Can I ask a question to Mr. Williams-Cook?
Yes, I'm listening.
Oh, are you a peer specialist at Fountain House?
Yes, I am.
Oh, many of the members at NAMI New York City Metro go to Fountain House and they speak very highly about it. They love it and they get a lot of help from Fountain House.
Yeah, in fact, the former facilitator of the advocacy group at NAMI New York Metro has invited me twice to be a speaker there. Or the advocacy group, a wonderful, group. I love New York, the New York Metro chapter of NAMI. I've been a part of it since 2010. They do fantastic work. Yes.
I'm quite active. I'll remind them when we open back up to have you come as a speaker.
I can put my email address in the chat.
Okay, thank you.
Great, and then I saw I saw that LaShawn answered about the documentary, but someone also asked a question that there's some misrepresentation about people who were previously unvaccinated and were anti-vax when in fact many people who are getting vaccinated didn't know that the vaccines were actually free. So what sort of non-social media, communication driven way can we reach underserved communities? If anyone has anything that they want to add.
Yeah, well, I just want to comment on that in terms of, I think historically in our people of color community, word of mouth is always so effective. We understand that a lot of folks, even at this present time, don't always have access to reliable internet, or I mean, newspapers are now online for the most part. So word of mouth is most effective. That's why it's so critical that we talk to each other, we share information. We have social hubs in our community for us to open up our mouths and talk to people about it. Not disrespecting or disregarding the other avenues that are available, but don't forget the word of mouth and the power of the word of mouth.
Just if I could just piggyback on that, Cecile. Absolutely. What has been key the last couple of days, the last couple of weeks since the weather has gotten better, is just me going to the community, introducing myself, talking, giving out flyers, and I played basketball with the guys, and really just ingratiating myself with the community. It's been so, the word of mouth just starts just funneling through. So that's really, a lot of the constituents don't really do Zoom. They don't do,
No.
they don't like computers and all that. So just being there has been helpful. You know?
That's right.
I think that even with word of mouth, you still want to be cautious of who you receive information from, right? Because that's what
Absolutely.
you're talking about, like misinformation that's provided online. And even though I always say, for me, social media is the easiest version. Follow people who are reputable people or reputable organizations that have consistently done the work. But definitely within the community, check in with local CBOs. A lot of community-based organizations have and provide information all the time from around mental health for vaccines and other different health related stuff. But as the policy girl, I say go to your political offices, right? Call them up or email them and ask them to join their listservs. They have an abundance of resources that come from your local hospitals and information that are coming from experts within the field and other mental health professionals, if it's on the mental health side, that they can connect you to. A lot of them host even right now virtually, and some of them have started to even move in person for some type of town halls and discussions and even forums that surround health related issues. So definitely get on those listservs as much as you can. And if you're not sure exactly who to call, you want to call like your assembly people, your city council, your state senators are the best offices to get in contact with those sort of information. Usually if you do anyone that's more congressional, and they'll send you back down locally. So you want to start with your local political offices. And if they don't have the information at hand where most people send it to them, they will definitely connect you to those individuals.
Mhm.
I just want to piggyback too, in our rural communities, a lot of the Department of Health folks are sending people of color to set up these hubs to offer vaccines, so that when you go, if you are a person of color, you see somebody that looks like you, and that you can talk about your fears of the vaccine, get information, like you said, from a reputable source, and to feel comfortable, so that's been working well for us. And that's when, we also send out our folks in the van with the Narcan training to show up at the hubs to offer mental health as well as substance abuse education. So we kind of try to, touch at all those points. But I think, again, having that representation of somebody that looks like you, that can understand you perhaps better, has seemed to work for us, when it comes to getting people vaccinated.
Mhm.
And I've also seen the rise in sort of mobile COVID testing sites and also vaccines. I don't live too far from Yankee Stadium, so and that helps with getting people into major sporting events, and that's popping up at Madison Square Garden and things like that. So I really appreciate that kind of access, especially if you're a sports fan and want to attend sporting events, that the city is making it possible to have rapid testing done not just in clinics but also these mobile vaccination sites, testing sites. I think that's important too when we talk about access to those type of services.
And I must compliment New York City, maybe New York State, but I've seen it more in the city, that they have made these resources specifically around the vaccine COVID-19 issues so much more available to our people of color community. But again, because of this history we have about vaccines, about resources, that still it's rest upon those of us who know to make the extra effort to inform those who don't, who not necessarily they don't know, but who are afraid or who are uncomfortable with accessing those very needed services. So as a community at large, it takes each one of us really to help the other in whatever form that help comes, because we need that. We need those services.
Right. And I'll just add, when the vaccine started coming out, I went to a Black-led community organizations webinar where they hosted people of color, doctors and researchers and participants who were getting the vaccine, as they began doing the studies. And, hearing, from people that look like you is much more comforting, people that you feel like you can trust. So,
Exactly.
as community leaders, right, it's, we have to use our voice, like Philip is saying, right? And, make sure that we're going to the basketball courts and we're talking to the people that, we care about in our communities and really just spreading the knowledge as much as we can.
So if I could just make a comment. So this conversation highlights one of my frustrations working with the rural population. Virtually everything that's said makes certain assumptions, none of which are true in the rural population. So when we kind of throw out these things, this is what we should do. Maybe in your environment, your context, that will work. But in a rural context, most of those things simply will not work. They don't have access to the kind of resources you're talking about. And what they do have access to, by the way, is dangerous. And telling them to contact their representative or whatever, that's virtually impossible for most of the people in our dispersed population without access to anything. So the only thing that seems to work is to find a trusted partner. Might be a town supervisor, might be a pastor, and access them. But all of those other things don't work.
They don't have access to a telephone?
You
Limited.
saw the number, 2,800
Yeah.
people in our population don't have access to a telephone.
Right, Dr. Turney, I totally agree with you. Me and Columbia and Green, there's all these grants out there for communication grants, right? But we don't have internet access. So
Exactly.
what is it going to do if I apply for the grant when we can't even provide, or these grants were for a laptop that you can get a discount of $100. Well, the thing costs what, $500, right? It's not going to
Yeah.
help the client.
Yeah.
So
Right.
yeah,
And
for
we had,
sure.
we
Very
had,
frustrating.
we had parents, so school districts, rural school districts are terribly underfunded.
Right.
So these kids during the pandemic were told to access internet because they didn't
Right.
have it at home, to drive to the school parking lot. You have a single mom who's trying to maintain her job, who now has to quit her job so she can get her 3 kids at different times during the day to sit in this high school parking lot while the other 2 kids are sitting in the back seat, of course, minding themselves, right? That's untenable.
That's right.
It just doesn't work. It simply adds to the traumas that these folks are dealing with already.
I agree.
I have a
And
friend.
my heart, oops, sorry. I was about to say, I was raised in a very rural community, very, very rural community. And so I understand and I share in the challenges that are there. But it's not, it goes back to what I said earlier. A lot of folks connect through language, through talking to each other. And I don't think that my mother would know what happened at school, and we didn't have a telephone, mind you, but she would know what happened at school before I got home. Because the network of people in the community made sure that whatever happened to each of the children in that school were communicated to parents or caregivers. So it's not a hopeless situation, Frank. I know it's dire. But
Just hold on a second. What if your nearest neighbor is a quarter mile away or a half mile away?
that was my that was my
I think you were
reality.
just answering specifically the person who were able to access today's webinar's question. I don't think that obviously there's a one-time, one-cut solution for everyone. So I completely understand your frustration because I have like a friend who actually is from a rural community and her work is significant in that space. But I think that some of the information and even like what you suggested, talking to pastors, talking to those community-based organizations, talking to various different people within the community is something that do what works for you or what you have access to, right? So obviously everything isn't going to be the digital way. Things may necessarily be sometimes, as much as a lot of things don't really go out, a lot of papers have been going out to homes and stuff in certain areas. That does have access to mail. Some places don't have significant access to mail. So it's really a matter of doing what works for you. And and it adds additional challenges, obviously, Frank, to the work that you do.
Mhm.
So that's commendable in itself.
Right, and I just want to add to LaShawn's point to just with the organization I was speaking about, they address many different issues. One is homelessness, so they obviously, are dealing with the same challenges that you do, where people don't have access to internet and they don't have access to telephone. So, I really want to highlight that the work that we're all doing in other community organizations is what's going to, really bridge these different gaps that we have. It's the work that we're doing and that we're discussing here all together and having these conversations and really trying to help each other figure out how we can do that and, see what the differences are and how, as just members of every community, we can come together and kind of work on this, because it does reach everyone in every different community and we have to be there for each other. So I just want to,
Yes,
yes, thank
yes.
you all so
Yes.
much. I know Wendy has a closing message for us today.
Thanks, Cass. Yeah, no, I just wanted to thank everyone for being here today, particularly our panelists. I think, in addition to a lot of the information that you gave, you've actually raised some issues that I know that I hadn't thought about before. So I do appreciate that. And since this is wrapping up our last Wellness Wednesday, I'll mention that, we had some great panelists join us for our previous sessions on transforming crisis response and workplace mental health and youth mental health. And we're recording all of them just as we're doing this one. So those are available for anyone who wants to access them. I'd like to thank Angela Krieg also for doing the graphic recording, which I think she might have dropped off at one point just for internet connection. So we'll get that up. She's back up. So Angela, did you have anything you wanted to say about?
Yeah, definitely. Frank, speaking of rural communities, I also am living in a rural community and my internet can be very, very spotty at times, but I still feel lucky as my parents still have dial-up internet, to give an idea. But this was a really fantastic talk with some really great perspectives, because my internet did drop off. I'm playing a little bit of catch up right now, but some really wonderful things were brought up. And Philip, thank you for letting me know that I spelled your name wrong when I didn't add the S at the end of Williams. I really appreciate that type of feedback. But I really hope that, you guys get this and this helps with memory, and it helps you remember the talk that was had and what everybody else has said and the names of the speakers.
Thanks so much, Angela. Angela did this all for free. She didn't charge us anything to do these. So, and we will be sharing these beautiful graphics with everyone and putting it out on our, our social media and our listserv. So thank you so much, Angela.
Okay, beautiful.
Yeah, and then
Thank
and the other person or entity I wanted to thank was Hannaford Supermarkets. They gave a grant to NAMI New York State, and that kind of made it possible for us to be able to bring you programs like this. So I just wanted to acknowledge their generosity as well in making this possible for us. So I really appreciate it. And I think Cassandra's going to mention some upcoming things, but this has been such a wonderful Mental Health Awareness Month, and you all helped to make that possible. So thank you so much.
Thank you.
Great, thank you. And just before I plug our upcoming event, I just want to mention that we want to let everyone know that our partners at New York State Psychiatric Institute Center of Excellence for Cultural Competency are promoting an initiative from hardship to hope, and their program will be launching in the fall, and it will be a peer-led financial wellness program for people experiencing financial hardship and recent thoughts of suicide, and it aims to address financial hardship as a social determinant of mental health and recovery. The center will be holding focus groups with peer providers and mental health clinicians in June to July. The focus groups will help the center develop a program that is feasible, acceptable, culturally appropriate, and effective as possible. So if you'd like to learn some more information about that, make sure that you check out our e-newsletter that's coming out tomorrow. And you can also email Matt, who's on our staff, and his email is matthew@NAMI-NYS.org. So you can learn more about that as well. And now just gonna share that tomorrow we are holding our NAMI Cafe. It's something that it's a virtual event we started last year, actually, as we were social distancing. It's an open mic night, so it's going to showcase the wonderful talents of different members from NAMI from across the state. So you can still register to come and attend and enjoy like a nice, great, fun way to end the Mental Health Awareness Month. And then just want to mention that, you know, even though Mental Health Awareness Month is ending, you can always still continue to participate in our ribbon campaign, where you can post one of our NAMI New York State ribbons in your home, outside, throughout your neighborhood, at your business place and park. So you can contact us to learn how you can get more involved, and contact your affiliate as well. And then until next Tuesday, we will be holding our Giving Tuesday campaign to just continue raising money to help provide our services, and really just I encourage everyone who's able to make a contribution if you can, to support NAMI New York State's mission to provide free mental health support, education, advocacy, and public awareness. So thank you all so much for joining us, and please look out for our recordings. They'll be in tomorrow's e-news. Thank you all.
Thank you.
Thank you all.
Thank you.
Thank you.
Have a wonderful rest of the week.
You too, and everyone, do a little self-care today. Maybe
Yes.
Yes.
a favorite song.
Have a great week.
Thank you. Bye.
Have a good holiday weekend.
You too.